All right, thank you, and glad everybody could join us today. And we are covering the Medicare Physician Fee Schedule final rule. So we're not going to go into the nitty-gritty code detail changes because that will be in our next webinar in a couple of weeks. Just kind of the basics, though. We have the disclaimers. At the time the presentation was created, the codes were correct. However, CMS does have a way of messing with our minds and republishing the HCPCS file, which they did, and had added 2 new HCPCS codes for drugs. So those are fun. But what we're going to be covering today was in the physician final rule. We'll touch on the evaluation and management visits, the updates to telehealth services, the post-pandemic supervision requirements, some drug updates, at least for the coding and reporting, the update to the colorectal cancer screening benefit. We'll discuss chronic pain and behavioral health updates, non-face-to-face remote therapeutic monitoring services. There's been an update to audiologist services that we'll cover, an expansion of some covered dental services, and then the HCPCS coding for the wound care management products, which is also called the skin substitutes. So we'll discuss some of those changes, and then kind of an update on the electronic prescribing that CMS put into place last year. So diving right into the E&M visit updates, in 2021, there was a really big expansion for the office outpatient visits that were based on the history exam or medical decision making. And for 2023, then the expansion then occurred throughout for the other outpatient visits that were based on the history exam and medical decision making. And for the most part, CMS says they are going to generally adopt the revised codes and the changes from the CPT recommendations, but of course, being CMS, there are going to be some definitions. So as you've probably heard by now, any of the codes that we're using, the history exam and medical decision-making as a component, have been updated, and except for the emergency department visits. Now those descriptions have been revised, but they were not changed to be time-based. And of course, where the main difference is in the prolonged service time reporting, because as with the other outpatient visits, CMS did not agree with CPT on the time reporting, and so they have created their own CPT codes or HCPCS codes for those. And then we'll touch a little bit on the shared and split visits, because there really wasn't much of an update on those. All right, so just kind of as a high level overview, there were some updates to the inpatient and observation care services. So what the CPT did when they went in and reviewed some of these, they thought, for a patient that's an inpatient at the hospital, or whether they're in observation care, the work that we do really isn't much different. So we can go ahead and combine those services, the CPT codes, and have just kind of one set. So they also did that with the nursing facility visits, because what the physician did for a patient that was in as a skilled nursing facility patient versus a nursing facility patient really wasn't that much different. So they just combined the codes to have then one set of codes for those types of patients. And we'll talk about some of the hot spots or trouble areas that you might see from that. And so there were, codes deleted. And so the hospital observation services codes have been deleted because they've been put in with the observation care guidelines. The low-level consultation codes were deleted. And so they kind of combined that with the rest of the consultation codes, so that they're basically the 4 main medical decision-making types, the low, straightforward, well, I've got that backwards, straightforward, moderate, straightforward, low, moderate, and high. And so the revision of the consultation E&M codes has taken place, plus also make sure to check the guidelines. And then the emergency department services codes have been revised. Also the guidelines, the nursing facility services have been deleted and revised just to make sure that they're all going into the same type of work that the physician does. And then for the prolonged services, the 99417 has been revised a little bit just in some of the guidelines. And then the CPT established the 99418 for prolonged services for the other office and E&M codes. So CMS has their own. When CPT first published their guidelines early so you could get a head start of them, the 99418 was a placeholder 993X0. And so I just wanted to highlight this on the slide to let you know that this is the permanent code for that service that was published. All right, so the services are no longer based on examination. It is going to be the moderately appropriate history or physical examination when it's performed. So it's no longer used as an element of selection in the E&M. So it's kind of nice that we won't have to go through and kind of count things, except for some of the other data to be calculated for this level of stuff. So it's really going to be based on the level of medical decision-making or the total time for services performed on the date of the encounter. And with these revisions, it's really nice because there were really only minimal updates to the medical decision-making table. And that's really in the low and the high. They just made some updates, but CPT also said, make sure you're checking the section guidelines so that you don't miss anything that's important when you're making your code selection. All right, so I wanted to put the emergency department visits here just so you could see what the new revised codes are. And so 99281 is not, it's going to be like a nurse visit because it may not require the presence of a physician or qualified healthcare professional. And then the 99282 then would be your straightforward medical decision-making. Your 99283 is going to be low level. 99284 is moderate. And then your 99285 is going to be your high level of medical decision-making. All right, and then some other examples that I wanted to provide here are for your nursing facility care per day. And this is for your medically straightforward or low level. And notice that it says the 99304 is your initial nursing facility care per day, and your 99307 is your subsequent nursing facility level care per day. So this is also going to be important, and we'll discuss that in a little bit. Now, well, the next slide is a matter of fact, because some categories can apply to both a new or established patient, and hospital, inpatient or observation care is one, the nursing facility level of care is another. The initial service, what CPT said was, it's kind of like a new versus established. So the initial is when the patient has not received any professional services during that admission and stay. So instead of being, the 3-year timeline for regular office E&M codes, it's during the patient's stay. And then subsequent services are reported after that initial, but they're borrowing the new and established patient definitions of, the physician or qualified healthcare professional of the same specialty in the same group and all of that fun stuff. And then if the provider's on call, then the patient's encounter is classified as if the unavailable physician or QHP provided the visits. Now, when CMS doesn't necessarily have a specialty designation for nurse practitioners and physician assistants, but what CPT is saying is when you have a nurse practitioner or a physician assistant that's working with a physician, then they want to consider that person as in the exact same specialty and subspecialty. And then the single stay is can be, if you have a patient that's in inpatient or observation services that might transition to inpatient, that's still the single stay. And so also for skilled nursing facility level, if the patient then transitions to nursing facility level of care, that's still a single stay. And that's how you would determine the initial from subsequent. It's still within that same stay. So you would not report initial when they change like a level of care. All right, so there are some areas of concern, so just things to watch out for. In the CPT guidelines, the CPT says, hey, if, we see the patient in the office and provide an evaluation and management service, and then later the patient ends up going to the hospital and being admitted or having to be admitted to a skilled nursing facility, then we should be able to put modifier 25 on that because it's two different bundles of work and the work done is very different. And CMS says, no, we don't agree with that. We still think only one evaluation and management service per calendar day should be reported. And CMS is saying that's because within the descriptions, you're saying per day for, like the initial hospital visit is per day. So anything performed on that day would be considered. So this can be concerning. So it's going to depend on your payer, whether or not they follow CPT guidelines or CMS guidelines. So that might be one thing that you want to watch out for. And then for the hospital inpatient or observation care, these are what you would call the admit and discharge on the same date or day management. These codes were revised. And so using total time, it goes by, you have the medical decision making or time on these. So normal, as you know. So one of the items that kind of pops into my head is, well, you have your hospital inpatient is place of service 21, but your observation care is an outpatient status. And so what place of service should we report? Well, if the patient's in the emergency department observation area, that could be 23, but if they're on another floor, then you might need to use a different place of service. It's the same code, so there will need to be some discussion between providers to make sure that they're letting you know, well, is the patient inpatient or are they in observation? And same with the nursing facility visits. Are they skilled nursing facility or are they nursing facility? Because those are two different place of service codes that need to be on your claim. And so that can be kind of lost in translation, if you will. So getting that information might be a pain point for you. All right, and then, so we have the admit and discharge on the same date. And then we have minimal updates to the discharge on the date of service. Now, one thing here is that they should only be used by the provider that's responsible for the discharge services. So it's possible that, another specialist has come in and seen the patient and provided some type of discharge instructions. If it's a hematologist, they might come in and say, well, I want you to go on, next Tuesday, get your blood work done here, have it sent to my office, but call me in the morning and make an appointment for 2 weeks. So that is some discharge instructions, but that hematologist may not be the one that's responsible for discharging the patient. So that hematologist might use the like the subsequent hospital visits for that service, because I'm assuming that they'd already seen the patient prior to that. So just something to be aware of, that it might be a little bit of a pain point for you. All right, so 99234 through the 99236 are the admit and discharge on the same day. And it's going to require 2 or more services, one for the initial admission or the encounter, and then one for the discharge encounter. So if you do all of that admit and discharge during the initial encounter, then you're going to report like the initial hospital or observation CPT code for that. Well, CMS then said, well, hey guys, we want to clarify this 8 to 24 hour rule. And so we kind of have a little bit of a different way that we see this. So, of course, their clarifications aren't always clarifications. But if the patient is there less than 8 hours, then use the initial hospital stay. If the patient's there at least 8 hours and discharged on the same calendar day, then you can use the 99234 through the 99236, which is the admit and discharge, on the same day. So, and then there was some more discussion on that, because when CMS says that they're doing their valuations for things, they're kind of taking this 8 to 24 hour rule, or the under 24 hours, into consideration where they're doing all of that. So it actually popped up a few times within the final rule. What's nice though is CMS did give a table, if you will, to kind of help navigate through which code should be reported. So if the patient's there less than 8 hours and they're discharged on the same calendar date as that admission or the start of observation, then you would report the initial hospital services only. And then if you have a patient is there 8 or more hours and they are discharged on the same calendar date, then you can use the same day admit and discharge services. Now, if you have where the patient's there less than 8 hours, but they're discharged on a different calendar date, then you would only report the initial hospitalization services. But if the patient's there more than 8 hours, and it's a different calendar date than the admission, then you can report the initial hospital services plus the discharge day management services. And for all of those, if there are prolonged services, then you can go ahead and report them together. Or yes. So just because you have a code to report does not mean that you're not able to report prolonged services if that occurs. You just have to meet the time thresholds. All right, now CMS also gave some reporting scenarios regarding emergency department visits and whether or not they are seen by 1 or more physicians at that time. So if the patient is admitted to a hospital or placed in observation status by their personal physician outside of the facility, then their expectation is that you would report that initial hospital services code, and you would only report 1 CPT code. Now, let's say the emergency department physician and the patient's personal physician or primary care provider, whichever, both see the patient in the ED, then it's acceptable that both physicians report an emergency department code. And where that can be an issue is if you have other payers that are saying, well, no, they can't have 2 ED visit codes. And so you kind of have to remember some of the different payer guidelines. And then also to make sure that the patient, the emergency department visit with the personal physician is not merely for that personal physician's convenience. So it's, just because their personal physician doesn't want to go down and have to open up the clinic to see the patient is not going to be a good excuse. It would have to, meet medical necessity, of course. Now, let's say the patient's there in the emergency department and the ED physician calls that patient's personal physician and all of the discussion is done by phone. Then only the emergency department physician gets to report a visit. The personal physician does not get to report a visit. And some other, couple more. So let's say the emergency department physician requests that another physician comes in and evaluates a patient. It could be an orthopedic or coronary, whatever specialty. So if the patient is just seen in the emergency department, then both the emergency department physician and that second physician can report the ED visit code. But if the ED physician requests that second physician come in and take a look at the patient, and that second physician decides to go ahead and admit the patient, then that second physician would go ahead and report the initial hospital visit codes. Now, CPT says that critical care and ED services may be provided on the same day, but there are some caveats there. You want to make sure that the E&M service was provided prior to the critical care when the patient did not require critical care. And then also they have to be separate and distinct. So it can't be that, the patient's there and codes as they go out the door, because it's not really a separate service. And it also needs to be medically necessary. So just kind of some of the pain points and coding scenarios that CMS provided to help kind of wrangle some of those questions that you might have. All right, now prolonged services. Of course, CMS has to be different from CPT because it can't be as easy as keeping things similar. You can see that CMS and CPT are trying to work together to kind of streamline some of this. And CMS is trying to get where they're paying providers for what they do. But sometimes it's like rock'em sock'em robots. They're trying to go until they knock somebody's head off. And one of those is the prolonged services. So similar to the normal office visit 99202 to 99215, prolonged services, there's a short update to the prolonged services HCPCS code that's used for CMS. But CMS is also saying, okay, well, we're going to do the same thing with all of these other office visit codes that we did with the other one, because they weren't able to figure out that CMS or that CPT was going in specific time increments in the codes. And so there's that additional 15-minute gap between CPT reporting and CMS reporting. So in the proposed rule, the GXXX1 was a placeholder, and G0316 is for the final code for this. So I kind of highlighted what this code does, because this wall of text is always so fun to look at. So the G0316 is for your hospital inpatient or observation care, and you use the time on the date of the primary service. It's for each additional 15 minutes, and it can be with or without direct patient contact. The rest of the kind of parentheticals tell you what you can list it with, what you can't list it with. And then I've also highlighted the 99418, because when this was originally published, it had that placeholder code of the 993X0. So there's one code for the hospital inpatient or observation. There's also the G0317, which is for your nursing facility visits. So using the time on the date of the primary service, each additional 15 minutes with or without direct patient contact, and then the direction of what you can and can't report it with. And then the G0318 is for your home or residence services, pretty much for the same thing, except for because it's home or residence, it can use the 99417 instead of the 99418. So I just have a couple of charts here. And so for the 99221, it covers from in the 40 minutes to 54 minutes. The 99222 covers from 55 to 74 minutes, etc. And then CPT says that when you hit 90 minutes, then you can report the 99418. And of course, CMS says, au contraire, you have to wait until you hit 105 minutes. So it just be careful, because it can sometimes seem a little crazy because the times for some of the different codes are different. So it's like, well, hey, why is it with this, it's at 105 minutes, but at this one, it's only 80 minutes. Well, these are for the subsequent hospital or inpatient observation codes, and the times in the descriptions are different. So just be careful to make sure that you're looking at the times in the code descriptions to determine, okay, when can we report that item or not? And then here's another, the admit or discharge on the same day. CPT says when you hit the 100 minutes or longer, and CMS says no, you have to wait until 125 minutes. I did include the outpatient consultations, well, and the inpatient consultation too. CMS did not come up with the code because they don't cover these. So it doesn't matter. You're not going to be reporting this to CMS anyway. And then the same with the inpatient observation consultation codes. All right. So kind of a little bit of an overview just to give you when you can have that, when you have that time threshold. So for the initial inpatient or observation, you would have to use the 99223 and hit 105 minutes. And then for each 15 minutes, you can include that prolonged code. So the subsequent inpatient or observation, it's still the same G code. It's just a different time threshold. So, be careful. And then it's kind of, the admit and discharge same day, same thing. So I've got a couple of slides here that are just tables to show those time thresholds. So you have an idea of what you're looking at. All right, so the split and shared visits, CMS did have a change published in the proposed rule, but they decided not to implement it, and it's been pushed to next year. So they are not going to define what they determine to be the substantive portion of the visit until January 1 of 2024. So their instructions were for this coming year, just continue doing what you've been doing. So one of the three key components of history, exam, or medical decision-making can be the substantive component, or more than half of the total time. And so the billing provider should be the one who provides that substantive portion. And then CMS is also going to be requesting provider input. So there's no additional information on, well, what if one provider does, the substantive portion is history, but the other one does a lot that's total time. That was not addressed. And so my advice would be to work with your MAC to see what their expectations are and to develop an internal policy to follow, and then apply that across the, your Medicare population, because as long as you get audited, if you're showing that, hey, we're doing this consistent and here's our policy, then the auditor should allow that. So also with CMS requesting the provider input, my advice would be to provide that input and say, hey, this is what we're seeing and this is what's happening. How would you like to see this addressed? Or, whatever your input is. So if you don't say anything, then CMS doesn't know what you're thinking or what you would like. And so it is nice that they are requesting input so that you can provide that guidance to them. So, really, this part, there's really a whole lot of nothing new. Just carry on with what you've been doing and check with your MAC for whatever they would have specific to your scenario, because I can almost guarantee the different MACs are going to have different guidance because they have different medical directors. All right. So after split and shared visits, let's take a look at telehealth services. So CMS did address things, kind of through the pandemic and beyond. So for the pandemic, there is what they're calling the 151-day extension that was allowed as part of the Consolidated Appropriations Act of 2019, I believe the year is. So what that does is it allows for the COVID-19 waivers and flexibilities to last for 151 days past the end of the pandemic. So once we get to that post-pandemic, then like the only audio services will be the mental health telehealth services. But CMS did say that they are going to be publishing some additional information to kind of help with the transition after that 151-day extension. On the website where they have the public health emergency declarations, there is a letter out there to the governors that says that CMS will provide a 60-day heads up when the PHE when they're not going to renew the public health emergency. I've not seen an update on that yet. And so since it was, let's see, the last one was in October and we have less than 60 days. So I'm assuming that the PHE will be renewed in January to get us through April. And I'm kind of assuming that they will also extend it past into July. And that will kind of then maybe have it die away, because that will get everything with that 151-day extension, that will get everything pretty much through the end of 2023. And then also another round of rulemaking. So then we can see what will be permanently changed and what won't be permanently changed. So the one thing about the pandemic is that CMS is seeing where telehealth services can be more helpful. So I'm sure there's much more that will be coming from that. And that's totally conjecture. That's just me kind of looking in through my crystal ball, but I have old eyes, so my eyes might be crazy. So anyway, so while we're still in the pandemic and we haven't hit that 152 days for that extension, continue to report services like you have done through the PHE. So that place of service is the same as if it's done face-to-face, same modifiers, and the telephone services, the 99441 through 99443 are going to be available. But what happens when we hit that 152 days after the PHE? Well, all of those waivers and flexibilities will end. So all of those additional practitioner waivers are going to end. So allowing, physical therapists, occupational therapists to be able to do therapy by telehealth is going to go away. Only professional health services are going to be covered. So it's not going to be, so the hospital outpatient departments aren't going to be able to report those services. It's going to revert to the pre-pandemic site of service definition. No longer report services as if they were in person. So that also means that those audio only services are only going to apply for those specific conditions. And at-home services are only going to apply for specific conditions. So it's going to be nice to see CMS come out with kind of some transition plans to help get through the, the cutting off of the waivers and flexibilities. So the place of service, O2, is going to revert to the originating site definition. So that would be, the O2 would be required for all Medicare telehealth claims, and that the exceptions are going to be for the mental health services. And I've got a list of those. So place of service 10 is going to be generally not covered by Medicare. But they have given the definition of, for those, the telehealth services are provided in the patient's home. And then the home might include like a hotel or a homeless shelter. And also, one nice thing that they have done is that if for privacy concerns or other personal reasons, the patient needs to go outside their home to be able to have the service, they're going to consider that as being in the home. So it could be that, if you're working with a battered woman, or, well, I shouldn't just say a battered woman because there are battered men as well. So where the person needs to be away from other people in the house, that, they can go outside or, to the barn or in their car to be able to have that privacy and to be able to still call that being in the home. All right, so those exceptions that I was talking about, so those are your mental health, telehealth services. It's going to include the substance use disorder treatments, and then where you have the co-occurring mental health and substance abuse services, and then your clinical assessments for patients with end-stage renal disease receiving home dialysis. So when you do have audio-only services, that's where you have your FQ, and that would be for use with your Medicare claims. 93 is pretty much the exact same thing, same definition as FQ, but it's CPT. So CPT says you can use it with our list of codes that are in our appendix, I think it's Appendix T. And then supervisors will still use the FR modifier, where you were supervising, the supervisor was present through that audio video communication technology. Now, there is some confusion because during the pandemic, you can use either or, FQ93 or both. So that's kind of a little mind-boggling. So I'm sure that'll probably cause some issues. So so after you hit that 152, that day 152, the FQ would be for your mental health audio services. And also only professional services would be reported for telehealth. And so they're not expecting to see anything reported for telehealth on a UB. And then the instructions for your modifier 95 will be unchanged. And then kind of to piggyback on top of the telehealth service updates, there are some changes to categories 1 and 3. And so the category 1 is for services that are similar to office visits. Category 2 are services that are not similar to those that are already on the telehealth services list. And then category 3 are those that have been added on a temporary basis, and they're supposed to be evaluated to see whether or not they should be permanently added. There were no changes to any of the Category 2 codes. And then CMS said what they're going to do is leave any services that are on that Category 3 to be on the telehealth services list through the end of 2023. So coverage of those services might be a little iffy depending on when the PHE ends and whether you're on day 151 or a day 152. So that can cause some confusion. And I think what CMS is doing is kind of wanting to get comments from people to see, okay, this is really working for our patients. Here's, the clinical outcomes that we've seen. And to be able to provide the data to CMS to say, oh, hey, you're right. We should leave those on the list, or these are working really great. Let's move them to, Category 1 or 2. So services that were not added as a Category 1 service are services like your physical therapy, because they did not meet Category 1 or Category 2 definition, but they will remain as a Category 3 service through the pandemic. And then CMS also said that the audio-only services are not going to remain after the PHE ends, and those are only going to be available for the mental health telehealth visit benefit. But the services that were added were the prolonged services codes, so they can, because they're similar to office visits. And then a new benefit category that we'll talk about in a few slides is the chronic pain management treatment. They have a monthly package benefit, and we'll discuss that when we get to the mental health updates. Now, for the Category 3 services, kind of the temporary stuff, they have added a few services, and I've got several slides, so I won't go over all of those. So they're going to leave these on in an interim basis, evaluate whether they can stay on, and then try to move them into the Category 1 or 2. So there's quite a few. I won't go into all of these because you'll have the slides and you can take a look. And for the telehealth originating site facility fee, that is increasing to $28.64. All right, so that is the end of our telehealth services stuff. So let's take a look at some of the post-pandemic supervision updates. And these are going to go beyond the COVID pandemic. So for direct supervision, CMS will continue to allow direct supervision through the virtual presence, at least through 2023. They are collecting data to see if that can be made permanent. So please make sure if you have any thoughts on that you do send them into CMS. And because CMS wants to allow providers to function at the full extent of their licensure. And so CMS does default to the state scope of practice licenses a lot. So also make sure that you're taking a look at those for the different providers. Now for the pulmonary rehab, cardiac and intensive cardiac rehab, after the pandemic, that will still require direct supervision. And the definition for direct supervision is going to revert back to requiring that immediate availability, meaning in-person physical availability, and it will not include virtual. So that's after the pandemic. All right, so not a ton of change there. There is an update to the mental health benefits, but I covered that in the mental health slides that we'll be going over here shortly. All right, now for the drug pricing and payment changes, CMS has added a new modifier called JZ. So when you're reporting wastage, you have the modifier JW, and CMS believes that it's underreported because CMS is monitoring the JW modifier to see, because manufacturers are supposed to refund Medicare money because of the wastage. And so when CMS is going back through stuff, they're saying, well, we think it's underreported. And so what they're wanting to do now is add modifier JZ, so which is zero drug amount discarded, not administered to any patient. So any separately payable drug that can be kind of refundable, which means it's kind of the single-use package or single-dose drug, where nothing is discarded or wasted, you would use JW. So for those separately payable single-use drugs, it's pretty much either going to have a JW or a JZ modifier. And while the modifier becomes effective January 1st, a lot of the payers did not think that they would be able to have their systems updated with enough time to get it in place by the first of the year. So what CMS says, okay, well, we'll give you 6 months. So you can begin use by July 1st, if not before. And then CMS is going to put edits in place starting October 1st of next year. So how would you use that? Well, your JW uses 2 line items. So you have your amount of your drug administered, and then the discarded amount is on a separate line with the JW. And so, but when there's no discarded amount, then you have that single line with the JZ. And so all of those single-use files that are payable under Part B should have a modifier, because CMS likes to have exceptions, because nothing can ever be easy. There are exceptions. And so that's your radiopharmaceuticals and imaging agents. So that will include your contrast agents. And then also your drugs requiring filtration. And that could be filtration, whether it's occurring prior to dilution and administration. The unused portion must be discarded after the filtration process. And some of the examples that CMS gave were for the liposomal products that require filtration. And so they're also going to put a time limit on it. So this is only going to be for drugs payable under Part B, fewer than 18 months, and then on or after. So that would be around November 15th of 2021. So there should be some more guidance, hopefully published by CMS, coming out soon to provide additional guidance. So it's not going to be every drug. So, and the hard part is that, the person who's doing the drug administration isn't necessarily the one doing the billing, so you won't always know. So you may have some discussions where you may need to plan out how are we going to communicate this information to make sure that we're getting it on the claim correctly. Because life is exciting that way. All right. Now, something that is kind of exciting to announce is that there is a benefit update to the colorectal screening benefit. I guess kind of. But the minimum age is changing to be 45. And it's going to be able to include a follow-on screening. So the 4 different items listed here. So your guaiac-based fecal occult blood tests. So if you have a positive stool test from one of these items, then you can have what they call a follow-on. So it's kind of it's not a follow-up, it is kind of a continuation of treatment. So if you have a guaiac and it tests positive for blood, then the patient can then go ahead and have a screening colonoscopy. So it's just a continuation of treatment. It's not a different, so it's not going to automatically change the benefit to being a diagnostic screening. We're just saying, okay, we got something that's testing positive here. Let's go ahead and do the screening, and then we'll go from there. So, and what that does though, is that there's no co-payment or co-insurance for the patient when they have that screening G code for that screening colonoscopy. So it's just that they can have that blood test positive, and then a screening. All right, so what happens though if that follow-on screening expands during the encounter, so they do have to go ahead and take some biopsies? Well, then it does go ahead and pop over to the other benefit where it becomes diagnostic. So it's going to follow that established process where you add the modifier PT, and then for the and then we're still kind of in that reducing coinsurance area where they're expecting to eventually get to 0% in 2030. And CMS said that their goal was to really to make the most appropriate choice for the patient's needs, because it's not always in the best interest of the patient to go ahead and do that whole colonoscopy where they're, and it might be easier to go ahead and just do the blood test or the Cologuard pill to go through the patient system and see, because CMS said that only 46% of the time in a screening colonoscopy did they ever have to remove any tissue. And so for the majority of the time, 54% of the time, everybody was fine. So it might be that they can just do like the GUIAC test or the Cologuard and be fine. But if something does come up positive on those, then they can go ahead and have the full screening. And so during the process in the final rule, CMS was asked if they could please, commenters asked CMS to be able to create some coding guidance. So, and CMS said they would, so you can expect some transmittals or Medler and Matters articles to be providing some more information as time comes on. All right, now another benefit is a chronic pain management and treatment. And there is this is a benefit update. And I've also put in here some behavioral health stuff, as they usually kind of go together. In the chronic pain management and treatment, there's a new monthly payment bundle with an add-on code. So of course, the wall of text here. And CMS said that they expect that this service could be provided by many types of providers. And so CMS thinks that, your primary care providers would use this, particularly where there aren't many specialists in the area, but it can also be provided by pain specialists, rheumatologists, or cancer care providers. And CMS wants to make sure that the patient receives a holistic approach to care. So you can see that this covers quite a bit of things. So, so the patient doesn't have to be diagnosed with chronic pain during this time, but through this service, the patient could then receive the chronic pain diagnosis. So let me go ahead. So there's, so it's diagnosis, assessment, monitoring, pain rating scale or tool, and it can also include overall treatment management, facilitation and coordination of care, medication management. So it needs to be provided by somebody that can write prescriptions. And then also, here is the add-on code. So at least in this one with the add-on code, at least the 15 minutes must be met or exceeded. So if you hit the 8-minute mark, you're still not going to be able to count it. And so both codes state that in their descriptors. And when CMS was looking at the payment for that, they used the principal care management codes to establish the relative value units. Now, how do you know if the patient has chronic pain? Well, CMS is going to define that as persistent or recurring pain lasting longer than 3 months. So of course, the MUE files usually lag a bit behind, but CMS said that the chronic pain treatment management bundles can be reported up to twice per month by up to 2 practitioners, because it's possible that, the primary care provider might be establishing treatment and saying, well, hey, now I want you to go to a pain specialist, or the cancer care provider could be providing some of those, but say, hey, I want you to go see this colleague. So they were saying it could be provided by quite a few people, but they'll only expect to see it, twice per month by up to 2 practitioners. So be sure that you take a look at the descriptions, because it has to be provided by somebody that can provide all of the service elements in that code description. And then CMS also said, hey, make sure you're obtaining consent for the services, and let the patient know that there's going to be a cost involved with this, just so that the patient's not blindsided saying, hey, I thought we were doing all this all for free. But no, I mean, the physicians need to get paid for what they're doing. All right. And CMS did provide some scenarios, and I just went ahead and went with one of them here. And so this is, an individual clinician sees a new patient who's seeking to establish care. And this example is a general internist. So they need to review the patient's history, and including current and prior medications and treatments tried. Probably want to know which ones worked, which ones didn't. Do some type of an examination to try to ascertain the source of the patient's symptoms, and then trying to get a functional assessment, and then start to develop a care plan as part of the visit. And so even though they're reviewing the medications, it doesn't mean that they would necessarily be changing anything during that visit, but it is possible. So it takes, both sides of the coin there. But it's important to remember that there is going to be some aspect of medication management. Also that, any referrals out to behavioral health clinicians, maybe a referral for substance abuse disorder or other pain management specialist. And then also to include scheduling a follow-up appointment with, the internist or general internist who is seeing this patient. And it can include, pain scales, and other types of assessments. And so with that, we will go ahead and go to the behavioral health services. With this, we have a supervision update and a benefit update, which is kind of nice. So for the supervision update, the old policy was the incident to services had to be provided under direct supervision, which meant that the physician was there and immediately available. What they're going to do is change it to be general supervision. And what this will do is allow your licensed professional counselors and marriage and family therapists to provide services without having to have that direct physical presence. And so this is going to, expand who can do this. So CMS, of course, is going to default to the state scope of practice laws. So is your provider is the person providing the incident to services allowed by your state laws to be able to provide that service? But you still have to follow the incident to rules. So that course of treatment has to be established by the physician or NPP, and the physician or NPP has to be demonstrating active participation in management of treatment. So there's no change to the definition of auxiliary staff. And it's interesting. I'm in Washington State, and one of the questions came up was that, well, in Washington State, we don't have LPCs, we have licensed mental health counselors. And CMS says, that's fine. That works for us too. But the main thing is if you're, it has to be within that provider's state scope of practice laws. And now if your state scope of practice laws doesn't define whether or not the auxiliary staff can provide behavioral health services, then it's going to revert to that direct supervision. All right, now, one of the new benefits here is a new code, and the definitions on the next page, because it, of course, is another wall of text. So for general behavioral health integration services, and this is for clinical psychologists and clinical social workers to be able to report the psychiatric collaborative care model work. And the GBH1I1 is becoming G0323. And I just wanted to caution you here because they're resurrecting a code that was deleted back in 2008. So the rule of thumb is after 5 years, the code can be reused. So if you have some old codes in your system, you'll want to double check to make sure that the code update gets done. And this was added to the list of services for general supervision. And when CMS was looking at the RVUs, they crosswalked it to the 99484. So you can kind of give you an idea of what the reimbursement for that will look like. All right, so here's the wall of text I told you about. So it's care management services for behavioral health conditions. So at least 20 minutes of clinical psychologist or social works time. And then it includes all kinds of notes there to give you the, the initial coordination of treatment and all of that fun stuff. All right, so the initiating visit might be your 90791, which is your psychiatric diagnostic evaluation by the CT or CSW. And so it can be billed during, during the same month as chronic care management or transitional care management services. But it's really important to remember that the service for the time should not overlap. CMS only wants to pay for each minute once. So kind of the double dipping is, you can't count the same minute for both chronic care management and the behavioral health integration. And of course, just let the patient know that you're providing these behavioral health integration services because there is a cost, just so they're not surprised when they're looking at their statements, because it's always a surprise to say, well, hey, I didn't know that had a cost. So it just kind of gives them a heads up. Now, for behavioral health services, there have been some status code updates just to kind of ease on restrictions. So for the family psychotherapy and multi-family group psychotherapy, they're going to change the status code from R restricted to A, and that is in hopes of removing any barriers to care. But just remember, it's not going to change any requirements in any national coverage decisions or local coverage determinations. So you still need to abide by those. All right. Now the remote therapeutic monitoring services, your non-face-to-face services, these are always interesting. There were 5 codes reported. There were 5 codes created in 2022 to report professional and technical services, so that there were ones for the physicians to report, and then ones to report when the patient came in to get the device and learn how to use it. And CMS had some misgivings because certain providers are not able to supervise incident to services, like your physical therapist. And so CMS proposed some new remote therapeutic monitoring codes to allow for coverage, but they ended up not finalizing those, which is kind of a bummer. But what did they finalize? So the RTM services may be provided under general supervision, which means that the supervising provider does not need to be specifically available. And then there's one new code, the 99878, for cognitive behavioral therapy device. And CMS is probably laying a lot of this back onto the MAC because they're not sure how the devices work with the treatment. So CMS said that they would work with the MACs on a national level to get some different information. All right. So after that, we have our audiologist services. And this is specifically for non-acute hearing conditions. And the update is that these are not going to need an order from a treating physician or NPP. And CMS said they wanted to be very certain that anything that might be an indicator for a serious condition would not be covered. So anything that is going to include a balance assessment for patients with disequilibrium is not going to be covered, and they're not going to cover vestibular function tests. Anything that might be, a neurological condition indicator or maybe a cancer condition indicator, they're not going to cover. They just want it to be for non-acute hearing conditions. It's because of patient safety. So after reviewing all of the comments, CMS had originally proposed a new HCPCS code for that service. And then the commenter said, well, why do that? Why don't you just use a CPT code and then create a modifier for those services to know that they're, being furnished without the order of the physician or non-physician practitioner. And CMS went, yay, that's a great idea. So that's what they've done. And so these next several slides are codes that can be provided using that modifier AB for the audiologist services for those non-acute hearing conditions. So I am just going to filter through these so you can go ahead and take a look at them at your leisure, if that's going to be something that you need to take a look at. All right, and we are getting closer. There is a dental services benefit update, and it's not, it's not a lot, but it's good enough. CMS received feedback from different people suggesting that that CMS's interpretation of the Social Security Act regarding dental services is too restrictive. And so, and that can contribute to the inequitable distribution of dental services for Medicare beneficiaries. And so CMS says, well, we think you're right. And in the proposed rule, they had 6 basic proposals and sought comments. And some of the items were to really just codify policies. And so we'll just kind of cover some of the updates that were finalized. And then CMS has also said they are going to go ahead and update the benefit policy manual. And one of the nice things is if the dental service is going to be covered, then so are like the x-rays, the OR room, and any supplies. And CMS is also seeking comments on whether other dental services integral to some medical treatment would be beneficial to improving those patient outcomes. So this is for parts A and B. So services performed as a comprehensive workup prior to like an organ transplant surgery. CMS did clarify that that is going to include your bone marrow or hematopoietic stem cell transplants, your cardiac valve replacement, valvuloplasty. They're adding head and neck cancers. And then also for treatment for a dental or oral infection that's found while they're doing this comprehensive workup. And it's going to be, eradicating that entire infection because that is going to cause an issue, prior to that organ transplant surgery. So there were a lot of updates that were finalized, and if I put them all in the slides, we'd never get done. And so please watch for clarifying updates in the Medicare Benefit Policy Manual, because if this applies to you. What they did not finalize were the services prior to the initiation of immunosuppressant therapy, joint replacements, and some other surgical procedures. And commenters said they would like some additional time to consider what other services that where the dental services are going to be beneficial for other covered medical services. And commenters also said, hey, it would really be nice to have some definitions to help guide our decision making when we're trying to figure this out. So, of course, CMS said that they will look at that and do some updating. Now, wound care management products had a lot of discussion and not a lot of changes, but what CMS did say was they came up with some key objectives and have a roadmap. And in this roadmap, they kind of are taking a 1 to 5 year approach. And what they want to do is make sure that they have a consistent payment approach across provider sites. So whether it's being done in the physician office or the hospital outpatient setting, they want to be able to make sure that it's done the same. And so they also wanted to make sure there's appropriate HCPCS codes to describe the products and put that in a uniform benefit category. And so what CMS said is that, what they're thinking is that Q codes should be treated as a drug or biological. And that, of course, is going to have a different payment methodology than items that are assigned to A codes that are going to be treated as supplies to another medical service. And so you can see that this is going to take a lot of work. So CMS did have a terminology change, and what they wanted to do is change from the terminology skin substitutes to wound care management products, because a lot of the codes that are in the A2 range, CMS didn't see them necessarily as a skin substitute. They viewed them more as a wound dressing. And so there was a lot of discussion around that. And so CMS said, okay, well, we're not going to change the terminology today or tomorrow, but we are going to change it starting January 2024, just so that we can have consistency and hopefully provide clarity. But I kind of get concerned when I hear CMS and clarity in the same sentence. And one of the reasons why CMS said that the A2000 to A2018 are not a substitute is because they're not necessarily grafted onto the wounds and they don't function as skin. And CMS said that their definition of skin substitutes does not include bandages or standard dressings. And there was a lot of discussion around deleting all of the Q codes and replacing them with A codes. And luckily that was not finalized, or the code changes would be really out of whack. But watch for town hall discussions and also additional rulemaking requests. And please be able to provide your input, because where that's going to come in handy is when we talk about reimbursement. And this is kind of looking at the 2024 range. So CMS is kind of giving you a year's heads up. So, because part of the problem is that the Q codes are supposed to be based on, the reimbursement is supposed to be based on that average sales price plus 6%. And then hospitals are reimbursed according to whether it's a high cost or low cost, but it's all packaged into payment for the procedure. And right now, the A codes are contractor priced. And for January of 2024, CMS wants to get the information to be able to get those skin substitute products that are commonly provided in physician offices, kind of reimbursed under the incident to supplies, and package the payment for those into the practice expense RVUs for the skin grafting procedures. So that would entail gathering quite a lot of cost information and invoice information for all of the different skin substitutes. And to me, it seems like it's going to be a nightmare. And so that is, so that's coming for the next year. So that's why it's important for you to watch for town halls and to provide your input and to see where that's going. So it could be that it will take longer than next year to be able to get all of that information gathered and available for use. So what I wanted to do was just kind of give you some future coding updates. And this is kind of looking into the crystal ball. This is kind of what CMS wanted, but was not finalized. They want to assign A codes to all skin substitutes that are not drugs or biologicals, and to discontinue the Q codes for skin substitutes. And so that would entail any manufacturer that has a Q code to submit a new application to obtain an A code. And when they submit that application, then they would be required to submit the letter from the FDA's tissue reference group along with that. And that would give CMS the information as to whether or not it's a biological or a synthetic, and whether it should go. So just kind of keep this in the back of your mind. It's not anything that was finalized, but it could be coming. And these could be part of the town hall discussion. So just to be prepared. All right. Now for the electronic prescribing updates, and this deals with the electronic prescribing of controlled substances. And this was something that was set up due to the Substance Use Disorder Prevention. Anyway, it's the Support Act, which is, the acronym is so much easier to say. And that mandated the electronic prescribing of Schedule 2, 3, 4, or 5 drugs under the Medicare Part B. And the compliance date was set for January 1st. And except for long-term care facilities, then it's the 2025. And there was a small prescriber exception, and that was described as a person who issues fewer than 100 Part D controlled substance prescription. And this was in last year's final rule. And this year they did some tweaking. And part of that was they made some changes to the small prescriber exception. So what the original part is that they would say, okay, well, you prescribe in 2022 and we'll take a look at 2023, and that will be how we view you for whether you're a small prescriber or not. And so CMS says, well, yeah, that's not going to work because when we did the evaluation on that, we used the current year to see if that provider qualifies for the small prescriber exception. So that's what they're going to do, is they're going to use the current year information to see if you're going to hit that 100 prescription minimum. So once that prescriber or the provider hits that 100 prescription minimum, then the compliance threshold is 70%. So once you hit that 100%, are you electronically prescribing at least 70% of your Schedule 2, 3, 4, or 5 drugs for Medicare Part D. CMS did acknowledge that there were some issues with buprenorphine, and sorry, I butchered that, prescriptions, but those were really less than 2% of the prescriptions. And so CMS says, well, hey, if you're having issues with electronic prescribing for those, request a waiver, and then document why you're not complying with that regulation, and then we will be good. All right. And guess what? We are at the end. Can you believe it? And I just wanted to say thank you. And for the references, I have the CMS final rule website and the CPT evaluation and management page, their microsite. All right.
Awesome.
And
oh, sorry, Artis. I was just going to say, I know we have a lot of questions and we will get to what we can. Just before we get started with that, I'm just going to launch a quick poll that asks if anybody is interested in being contacted by a sales representative to schedule more time to learn about our products and services. If you're not interested, that's totally okay. Just don't answer it or go ahead and click no. I'll leave this up for just a short amount of time and then we can go ahead and start with the Q&A.
all righty.
Okay, I think that's good.
All righty. Okay. And I will, let's see. So one of the questions is there a time limit on how many 99418 units can be reported with the 99223? At this point, no, there is not an established limit. The MUE files were dropped this morning, and I have not gone in to look to see if the 99418 is on this. And quite often what CMS will do is wait a quarter and then establish MUEs for things, just to kind of give you a quarter to kind of get your bearings. But I can go ahead and take a look and see if that's in the MUE file and let you know that. All right. And then should the key components really remain the history, physical exam, and MDM, when MDM is really the only component required in 2023? And I'm going to assume that you're discussing the shared and split visits. And that was kind of one of the discussions that CMS had. And they didn't want to answer that. And that's why that was pushed off until next year, so that they can get the comments and see what is going to work. They were going to change it to be where it would be MDM or time, but decided not to finalize that. So it is going to be, so that part is still up in the air. All right, for prolonged services. For outpatient, I thought the crosswalk was to G2212. Is this not correct? And if yes, could this code be billed by the facility, and what would the time threshold be? Well, for prolonged services, the G2212 is specifically only for the regular E&M code services, the 99202 through the 99215. There are the new G03161718 are for the new prolonged services, for the new E&M services that were related. And for and I will have to get back to you on the facility reporting, because I don't remember the status indicators right off the top of my head. All right, and then the August 22 CPT assistant says, accept services provided in the ED. Any update on that? No, there hasn't been any update on that, but I will go double check the CPT assistant. And then just remember that the ED visit with the, inpatient admit is going to be a difference between CPT guidance and CMS guidance. So that is going to be kind of the fight of the century, I guess. All right, so, okay, so for the ED level changes, does this or should this change how the facility bills ED levels? No, it should not change how a facility reports the ED levels. Just make sure that if there's any kind of change on how the change on the resource intensity affects your internal leveling, to make sure there are no changes, but the ED level changes are for the physician side. The one is the 99281 is now kind of like a nurse visit, but that still needs to be something under the direction of a physician. So it would be something more along the lines where the patient is coming back for like a suture removal or staples removal, or like they were at the emergency department, a few days before, and the doctor says, hey, come back in a couple of days and the nurse will change the bandages, those types of things. All right, is the FR modifier appended for all services for direct supervision through two-way audio video communication, or is this only for mental health services through telehealth? That is only for the mental health services through telehealth. And let's see. And for JZ only status indicator K and G on the facility side, yes, that's how you check to see if it's separately payable. So it's for anything that you would have that would be separately payable that's in a single use file would need to be would use that JZ, and then if there's wastage, you would use the JW. And did the presenter state that hospitals will not be able to report telehealth after the PHE ends? I didn't see it detailed on the slide, but briefly heard a statement. Well, yes, you're correct. This is kind of going over the physician final rules. So I kind of base this mostly on people that would be doing physician coding and billing. But yes, CMS is stating that after it's that 151-day extension, after that is passed, then they're expecting that everything would revert back to normal, and everything would go back to where, to be an originating site, the patient would have to come to your facility for you to be able to use that Q3014 code, and then the physician would be on, at the other site and report that their visit. So yes. All right.
Did you want to do one more, or should we wrap it up, Artis?
Yeah, let's see. I was trying to pick one. So for the CPM services, if they are provided in a hospital outpatient department, is there an amount that can be billed? And I will have to go and double check. I don't remember. I believe that it's only professional services that can be billed, and that for facility services, it's either a status indicator B, which is bundled, or M, which is not reportable. So I will double check.
Awesome. Well, I think that takes us to our full hour and a half. So we won't keep anyone any longer, but there still are a lot of unanswered questions. So we will make sure to get those answered and posted to our website for you. So just keep checking back maybe within a week or two, and we'll have those up. And like I said earlier, we will send out an email by end of day tomorrow with a link to the presentation, recording, and the CEU certificates. And if you don't receive them, just reach out and we can make sure to help you get those. I think that's all for today. Thank you everyone so much for joining us. Have a great rest of your day.
Thank you.
Thanks.